So good afternoon. It's a real pleasure to be here with you today. Again, I am based in Kenya, but today I'll be telling you about trials that we've conducted in Uganda to evaluate the impact of insecticide-treated nets against malaria. And I'll just start with the caveat that no, I don't think that nets alone can eliminate malaria. So we'll just start off with that. So as many of you know, insecticide-treated nets are the cornerstone for vector control against malaria in Africa. So in the 1990s, placebo-controlled trials definitively showed that ITNs reduced malaria incidence by 50% and all-cause mortality by 20%. So in Uganda, the Ministry of Health is committed to providing ITNs nationwide. And the picture here shows nets being distributed to hard-to-reach areas in Uganda. So this is done through mass distribution campaigns conducted every 3 to 4 years, and that's been done since 2013. They aim for universal coverage, and that's defined as 1 net for every 2 household residents. Unfortunately, pyrethroid resistance threatens the effectiveness of ITNs. So from 2000 to 2015, over that 15-year period, prevalence of falciparum malaria in Africa fell by 50% and incidence fell by 40%. That was primarily attributed to the scale-up of ITNs and other control interventions. But since then, progress on malaria control has stalled. And this is due to multiple factors, including the emergence and spread of insecticide resistance. So I've shown here a map that's from the WHO's malaria threats map that's focusing on insecticide resistance, primarily pyrethroid resistance, and you can appreciate that it's widespread. So to tackle pyrethroid resistance, next generation ITNs have been developed that incorporate the pyrethroid insecticide that all currently available nets incorporate, plus an additional agent, including piperonyl butoxide, or PBO, which is a synergist, pyriproxyfen, which is an insect growth regulator, and chlorfenapyr, which is a novel pyrrole insecticide. So all of these new nets have been pre-qualified by the WHO over the past 8 years. So I'm going to tell you now about trials that we've done in Uganda that we call LINE-UP. So that stands for LLIN Evaluation in Uganda Project. So working closely with the Ugandan Ministry of Health, we've embedded cluster randomized trials into mass distribution campaigns to evaluate the effectiveness of nets in Uganda. So how did we design the first trial? So the Ugandan Ministry of Health was already planning to distribute nets in their mass distribution campaign in 2017 and 2018. So the National Malaria Control Program Manager, Jimmy Opigo, was working with the Against Malaria Foundation to procure the PBO nets, and they were in support of the trial. So the cost of the nets and the cost of delivering the nets was already going to be covered by the National Malaria Control Program in Uganda. So our aim was to evaluate the effectiveness of PBO nets as compared to pyrethroid-only nets in the context of insecticide resistance in Uganda. So the WHO's VCAG, the Vector Control Advisory Group, requires 2 large epidemiological trials to evaluate interventions in order to make recommendations. So a trial had already been done in Tanzania showing the superiority of PBO nets, and so our trial in Uganda stood to be the second such trial to support WHO's recommendations. So we assembled a team led by Janet Hemingway and Martin Donnelly, myself, our colleagues in Uganda and in San Francisco. And we worked with the Ministry of Health to embed the trial into the planned universal coverage campaign. So the study team did the randomization, and we conducted the evaluation, and the Ministry of Health delivered the nets. So LINE-UP was the largest cluster randomized trial of nets that has been conducted in Africa to date. So we distributed over 8 million nets as part of the intervention. And this was an opportunity for us to not only conduct good science, but also to work closely and build the collaboration between the researchers, the implementers, and the funders. So a little bit more about the trial design. So again, this was a cluster randomized trial. A cluster in this trial was defined as a health subdistrict. And we worked in 104 health subdistricts covering 48 districts. And as you can see here on the map, we covered about 40% of the country. We had 4 arms in the trial, including 2 types of PBO nets and 2 types of pyrethroid-only non-PBO nets. So in total, we had 52 clusters per arm. The evaluation included repeated cross-sectional surveys that were conducted at baseline and then at 4 time points over 25 months of follow-up. The primary outcome was parasite prevalence by microscopy in children aged 2 to 10 years. We also had a variety of secondary outcomes. So these are the results. Again, we were comparing PBO nets to pyrethroid-only non-PBO nets. And you can see in the graph on the left, the blue line represents the PBO arm, and the red line is the non-PBO arm. So we found that PBO nets were superior to the pyrethroid-only non-PBO nets at each time point up to 25 months. So in both study arms, parasite prevalence dropped substantially from baseline. You can see that at 6 months, but you can also appreciate that prevalence never dropped below 10%. And then it remained low up to 18 months and then began to increase at 25 months. And that coincided with a decrease in LLIN coverage and use that we saw at 25 months. So moving on to lineup 2. So again, working closely with the Ministry of Health, we embedded another cluster randomized trial into the next universal coverage campaign conducted in 2020 and 2021. So for this trial, we were comparing piraproxifene nets against PBO nets. But this trial had a different study design. So I think you can see here from the map that we're working in a different area, really focusing on the north of the country and the eastern areas. These are areas of very high transmission areas with high level pyrethroid resistance. These were districts that were not scheduled to receive IRS. So for this trial, we layered it on top of an existing malaria surveillance platform that we've established with the Uganda Malaria Surveillance Project, where we are doing health facility-based surveillance at health center 3s and 4s. We call those malaria reference centers, or MRCs. So that's an enhanced health facility surveillance. So we layered this study on top of that surveillance platform. We had 64 clusters, and the clusters in this trial were defined as the MRC, that's the dot there on the maps, and then the target area, which ranged from 1 to 7 villages surrounding the MRC. We established the population of that target area through a census survey prior to starting the study. So we had 64 MRCs covering 32 districts. That was 2 MRCs per district, randomized 1-to-1, so 32 clusters per arm. The primary outcome for this study was malaria incidence, as measured in our malaria surveillance platform at the MRCs. We also had a variety of secondary outcomes, including parasite prevalence, again in children aged 2 to 10, that we measured through our cross-sectional surveys that were done similarly to what we did in lineup, the first lineup study, but less regularly. So again, here are the results of the primary outcome for malaria incidence. And this is showing malaria incidence per 1,000 person years on the y-axis, and then time up to 24 months on the x-axis. And we saw that malaria incidence after 24 months was lower than at baseline in both arms, but we saw no difference between the 2 study arms. And again, no difference in parasite prevalence, anemia, or bed net coverage between the 2 arms. We also did an interrupted time series analysis to see where we combined both of the study arms, so any LLINs versus the counterfactual of no nets. And we looked at that in year 1 and in year 2. And here we can see that we had a modest reduction in malaria incidence, but only in year 1. That was not sustained in year 2. So moving on then to lineup 3. So in this trial, we are evaluating comparing chlorfenapyr nets to PBO nets. So again, working with the Ministry of Health and AMF, the Against Malaria Foundation, we have established another cluster randomized trial, but this is in the 2023 UCC, Universal Coverage Campaign. This has a very similar design to what we did in lineup 2. But you can see that we're working in a smaller study area. Sadly, we had fewer resources for this study. So only 24 clusters here, 1 per district, randomized 1-to-1, so 12 clusters per arm. Very similar setup. We've layered this study as well on top of our malaria surveillance platform, and the primary outcome is malaria incidence, as it was for lineup 2. We also have the secondary outcomes that we're measuring in our cross-sectional surveys. So this shows preliminary results through September of this year. So again, showing malaria incidence per 1,000 person years and time. For here we had data 12 months prior to the net distribution, so that's shown there. The black dotted line shows the time of the net distribution, and then we have 9 months follow-up after that. So we do see that malaria incidence has dropped following distribution of the nets, and we perhaps some compelling results suggesting that the chlorfenapyr nets, which is the red line, might be performing better than the PBO nets, which is the blue line, but currently those results are not statistically significant. So this study is ongoing up to 24 months following the net distribution. So what lessons have we learned? So in lineup 1, we found that the PBO nets were superior to pyrethroid-only nets. In lineup 2, we saw no difference between in the effectiveness of the pyriproxyfen nets and the PBO nets. So both nets reduced malaria burden, but the duration of protection lasted only 1 year in our study. Lineup 3, interesting results, but the final results won't be available until early 2026, so watch this space. So we have learned through this process, this series of trials, that embedding trials into the national LLIN distribution campaign is a pragmatic and cost-effective approach for evaluating malaria control interventions on a large scale. This study design really fosters continuous engagement between the researchers and the policymakers, and really addresses the questions that they want answered. The National Malaria Control Program. So this model could also be used to evaluate combinations of interventions in the future. So in summary, LLINs are effective and they do reduce malaria burden, but the duration of protection in our studies has been shorter than expected. The WHO recommends that mass distribution campaigns be carried out every 3 years, but clearly, more frequent distribution would be required, although we recognize that's very logistically challenging. And we have certainly seen some of these challenges in the campaigns over the last 10 years, including the practice of capping nets, the number of nets that are distributed per household regardless of the number of residents. That leads to inadequate coverage, challenges with net attrition, where do the nets go after you've delivered them, reduced durability, and complicated behaviors around LLIN use, so the need to continually use the nets properly night after night after night. So I'll just in summary say that I believe that LLINs alone are not enough, certainly not enough to eliminate malaria. We need to combine interventions to reduce transmission, particularly in high transmission, high burden areas, and I think we'll hear more about that in the rest of the session. So many thanks. This is a lot of work that's gone into this. Many people have been involved, but thanks to the investigators, our funders, partners, and collaborators, and thank you for your time.
Thank you, Sarah. I love it when something comes together that people say are impossible. So when we set up that trial in Uganda at that sort of scale, operating in the national distribution system, I think everybody thought we were mad and we'd never pull it off. But thanks to Sarah on the ground and Moses, I think it was a great collaboration. So moving on to Grant now, who's going to talk about transmission and Wolbachia.
Thank you. So I'd like to chat to you today about some of the prospects for using Wolbachia for malaria control and some of our recent progress on that topic. So Wolbachia is an intracellular symbiote that affects many different insects. You could be familiar with it from the work done in worms, but perhaps also from the recent success of Wolbachia control in Aedes mosquitoes, which has been hugely successful to control Aedes-borne disease. So Wolbachia can do two things which make it highly desirable for applied control strategies. It can manipulate the reproduction of its host, so that allows it to spread through populations. And when you transfer Wolbachia into a new insect species, Wolbachia can block pathogens. And so people have exploited those two characteristics for different types of control. The first is population suppression, where you rear up huge numbers, millions if not billions of males that have Wolbachia, and you release these into the population. These males will mate with their uninfected female counterparts, and that cross is not viable, and so that crashes the population. Another approach is where you release both males and females, and Wolbachia spreads through the population, and now you've transformed a mosquito population that could transmit into one that can't transmit. And so, importantly, both these types of strategies have been employed and to show have epidemiologically relevant effects where they're reducing disease. So that's in Aedes, which has had huge success. And so when we think about what's happened in the Anopheles field, it hasn't progressed as far as what the work has done in Aedes. So when I was a fresh-faced postdoc, perhaps 15 years ago, I did some research where I would inject Wolbachia into mosquitoes, and we did this because we didn't have a stable line at the time. And then I exposed those mosquitoes to Plasmodium falciparum, and we showed that Wolbachia can indeed block falciparum in a mosquito that has Wolbachia. So that was encouraging. A couple of years later, there was some groundbreaking work where a stable infection was made in Anopheles stevensii. And so that was groundbreaking for a couple of reasons. Firstly, it showed you could infect Anopheles mosquitoes with Wolbachia, that they cause the reproductive manipulation in the mosquito. And you can see on the graph on the right, they're reducing the number of sporozoites in a mosquito. So that ALB strain there of Wolbachia from Aedes albopictus, when put into stevensii, reduces Plasmodium. So that was hugely promising, but we haven't had releases of Wolbachia in the field like we have in Aedes. And that's because those mosquitoes have a huge fitness cost. They're basically sick. So despite Wolbachia inducing those phenotypes, those fitness costs prevent the applied use of that type of strain. But what it did is it encouraged the Wolbachia community to look for other strains that could be useful for Anopheles. So there's a flurry of different papers. There's been some question marks on some of those papers, but if you want, these are extraordinary claims in the Wolbachia world, so you need extraordinary evidence, and hopefully I can show you that you'll think the evidence that we've got is robust, demonstrating that we do have infections. And so we're really optimistic about these two infections that we've identified in Anopheles muscetti and Anopheles demilioni mosquitoes, because we think that these strains, which naturally reside in an Anopheles mosquito, can be transferred to other Anopheles, like Anopheles stevensii or Anopheles gambiae, and they won't cause those severe fitness costs that you see in the mosquito. So we've done some work where we've done PCR-based screening approaches. We've done this in Cameroon, the DRC, and Kenya. And we've identified high prevalence infections in Anopheles demilioni and muscetti over different geographic spaces and over time. These infections are prevalent over different time periods. So this was very encouraging. When we look at the phylogenetics of these strains, they're grouping together, so suggesting that they're the same strain in these mosquitoes, which fits into what you'd expect for a Wolbachia infection in a mosquito. We've done a variety of different approaches to characterise these strains. Here you're looking at microbiome data, looking at mosquitoes that were infected or not by PCR, or discriminated by PCR. And when Wolbachia was present in the mosquito, it's at a high density. Here you're looking at the Wolbachia reads compared to the total microbiome, and so Wolbachia is taking up at least 50% of the microbiome, perhaps even more across different time periods and across different tissues in these two different mosquitoes. Seeing is truly believing, and so we've done microscopy, and this was very important that we could actually visualise the infection. Here you're looking at a cross-section of an Anopheles machete mosquito, and we've labelled the Wolbachia using fluorescent in situ hybridisation with a fluorescent probe. So the red signal that you can see is the Wolbachia infection, and this is in the developing oocyte, which would turn into the egg which is laid. And so Wolbachia is vertically transmitted, and so this is exactly where you'd expect to see Wolbachia, so that Wolbachia can be passed down to the next generation. You can see that punctate sort of signal, which is indicative of Wolbachia infection in these mosquitoes. And we can compare the infection in Anopheles machete to other Wolbachia strains that have been identified. And so here on the left at the bottom, you have Aedes albopictus, which is a strain of Wolbachia, that's a strain of mosquito which is naturally infected with Wolbachia. The one to the right, let's see if I can get this to work. Yep. That one there is the stable infection in Anopheles stevensii that has been developed. And so you could argue that the natural infection has a higher density compared to the artificial infection. Again, some work I was doing as a postdoc. When we injected Wolbachia into the mosquito to see if it would migrate to the germline. It did so, but it did so quite poorly. And the final image there is some reports of Anopheles gambia infected with Wolbachia, and so you can see that the signal is very weak there. But the take-home message is here, we can identify and visualise Wolbachia in the germline of Anopheles machete mosquitoes. Again, we wanted to look at diverse techniques to characterise and identify the infection. Here you can see some sequencing data. The green indicates arthropods that are known to be infected with Wolbachia. And so we've got our Anopheles machete and Demolioni highlighted in that red dotted box. And what we've done is mapped the sequencing reads to a variety of different Wolbachia strains on the x-axis there. And what you can see is that the Anopheles machete and the Anopheles demolioni have a similar pattern of genome breadth and genome depth when we do these sequencing in these insects or in these arthropods. But importantly, the other Anophelines do not have that. So indeed suggesting that Anopheles demolioni and machete are truly infected, where there's question marks about the other Anopheles and Aedes aegypti, which is known to be uninfected. So we've used a variety of different approaches to characterise these infections in these two more obscure Anophelines that really there is less research done compared to other Anopheles. And so now we want to use these for translational-based approaches, as I mentioned, because we feel these will, when transferred into other Anopheles, won't induce those severe fitness costs. And so we've been working towards that. To do that, we need to get Wolbachia in the lab, because to transfer Wolbachia between species, you need to inject embryos. So we're working on two approaches to actually get Wolbachia into the lab so we can go ahead and do those injections. The first is to colonise these mosquitoes, and so we're working with our partners in the DRC and Cameroon to do this colonisation work. Here we've put in a traffic light system, if you like, to indicate things that we can do well, things that are challenging and things that are really hard. But it's not a trivial process to colonise these mosquitoes. Little's known about them, but we're working through and made some success. Here you can see that we're in the final stages of trying to get the machete to lay eggs, but we can see that we can dissect mosquitoes, and they do have eggs, and we've got some evidence that those eggs can be laid, although there's only a few there, but we can work towards increasing that to start a colony. The other thing with the Anopheles demolioni, we can get high numbers of these mosquitoes to Liverpool, and so that we can work to try and transfer the Wolbachia from the mosquito into cell lines, which is the second approach that we're trying to actually isolate the Wolbachia and have it so we can work with it in the lab. So we're working at LSTM, but also with our partners in CRID, trying to culture Wolbachia in a cell line. We've done a variety of different approaches. We're using different materials, so we're looking at using the eggs or looking at using the mosquitoes themselves. The microscopy image there you can see is a cell that's heavily infected with Wolbachia when we used homogenised eggs. That looks very encouraging, but we only see very few cells in a cell population that's infected, so much so that it's almost at the limits of detection. And so we're working to see how we can increase the infection frequency. When we've used ovaries as the inoculation source, we see that we can get Wolbachia to replicate, but we're getting after 9 or 10 passages that crashes out. And that's pretty typical when you put Wolbachia into cell line. You get these stochastic variations in the density. Unfortunately, here it's meant that we've lost it, but what we're hoping is instead of using 15 ovaries, we can use 100 ovaries, we can use 1,000 ovaries, and that density will overcome those challenges with that stochastic variation in cell lines. We're also working with the tick cell biobank here at Liverpool to create primary cell lines, so we can make a cell line derived from these Anopheles macheti and Anopheles demolioni. And because those mosquitoes have Wolbachia, our hope is that we'll culture the Wolbachia when we make that cell line. So to do this, we practice basically with Anopheles stevensii, and here you can see an image of a cell line. That's after 18 months of being in culture. And we've got that monolayer of cells, and we've got these spheroids of cells. So we're confident that we've now made this novel Anopheles stevensii cell line, and using those optimized approaches, we've now done that with Anopheles macheti. So that image there you can see of macheti, you can see a piece of tissue, and you've got cells radiating out that we hope will continue to replicate and look like the Anopheles stevensii cell line. We just have to basically wait and leave that for a year, and then we'll get to a cell line like that. But as I said, good things come to those who wait, and we hope that Wolbachia will be in there, and we're confident that will be the case. So, in summary, what I've shown to you today is that Wolbachia can block Plasmodium. We've got a paper coming out soon to show that it blocks Onyongyong virus, which is a virus transmitted by Anopheles as well, and so that would be useful for population replacement type strategies. We've identified these 2 novel strains of Wolbachia, and we're very optimistic that we can use these for vector control in Anopheles gambians and stevensii moving forward. So it's very much collaborative work, thanks to all the people in the lab at LSTM. We're working with partners at the University of Warwick, CRSN in the DRC, and OSIAC and CRID in Cameroon. Thanks to all our funding, particularly the Gates Foundation for their continued support. And I'm pleased to say we've just been informed we've got a BBSRC grant on this to work on the more mechanistic aspects of this control. So thanks very much.
Thanks, Grant. So we're now going to very rapidly transfer over to Are Vaccines the Answer? And Adrian.
Great, thank you. Well, I hope they'll be part of the answer, at least. So, malaria is complex. These are our list of excuses for not having made a malaria vaccine until very, 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 very recently. Lots of genes, which is the best. In bold, antigenic polymorphism, particularly at the blood stage. And the parasite, unlike COVID, has had about 30 million years to think about our immune system. COVID had a few weeks. Worse than that, you need very, very high levels of antibodies that you don't get with other standard vaccines to protect against malaria at the sporozoite stage, and other stages look even more difficult. Cellular immunity, partly useful, but not good enough. So you do have 4 shots on goal at the different stages of the life cycle. I'll talk mainly about sporozoites. Liver stage, we worked on for years, hasn't worked. Blood stage, looking very exciting. My colleague Simon Draper in Oxford has an RH5 vaccine. There's a preprint out showing over 50% efficacy, first time with a blood stage vaccine. And then, very relevant to elimination, lots of mosquito stage vaccines coming along. So briefly, let's look at what's licensed. There are 2 malaria vaccines, RTSS, going back to, well, the 1980s, and R21, much more recent. They are similar, but not the same, and certainly not the same in efficacy. RTSS has 4 molecules of hepatitis B surface antigen for every molecule that has malaria, and both of them are nanoparticles on a hepatitis B platform. So you can see on the right, dotting of malaria antigens on RTSS. On the left, R21 has every hep B molecule fused to part of the circumsporozoite protein, which, as you know, has a conserved region in the center of NAMP, repeated 20 to 30 times. So we both companies, GSK and Serum Institute, who we collaborate with, use a saponin adjuvant, which is an excellent technology for inducing very high antibody levels. But the differences between the vaccines are relevant to policy and deployment as well. We can use a fifth of the dose, 5 micrograms, rather than 25, mainly because we have much higher proportions of malaria in there. Much lower cost, really because of the scale of manufacture of the Serum Institute I'll come to in a moment. Higher efficacy, I'll show you the data. And very importantly, better durability. And this is Kath Collins, who made the R21 for her PhD in the right-hand corner there. Serum Institute we collaborated with for COVID-19. They, with us, saved over 6 million lives from widespread distribution of an inexpensive vaccine. And of course, importantly for malaria, they are the predominant, and have been for many years, the predominant vaccine supplier to Africa, not just of EPI vaccines, but then COVID in 2021, and now malaria vaccines. The first efficacy trial we did with R21, skipping the challenge trials, which I'll not cover, was with Halidou Tinto's group in Burkina Faso. Very simple design, changing the adjuvant concentration from 25 to 50 micrograms compared to a rabies control. And very quickly, over a single malaria season and a year's follow-up, we saw 77% efficacy, importantly exceeding the WHO's goal for 2030 for a malaria vaccine. But that was only over a year, but very highly statistically significant, as you can see on there. Is it better than RTSS? Well, that's no longer an issue. It's very, very different, probably 50% more than RTSS produces on its own, not just in this trial, but comparing the phase 3 data. On the phase 2 data, after 4 years, it's 36%, playing 64%, so better durable efficacy. And the reason we were expecting that is a higher density of antigen on a nanoparticle surface, as in, say, the human papillomavirus vaccine that some of you will know, gives you durable efficacy for a lifetime, preventing cervical cancer, gives you better quality, more avid, more sticky antibodies that are more durable, and that's why we were pleased to see what we were aiming for, more durable efficacy. So let's briefly look at the phase 3 trial. 5 sites in Africa and 5 fantastic principal investigators, as you can see here. 2-to-1 randomization of malaria vaccine against control rabies vaccine. And after a year, in the target age group of young African children, 5 to 17-month-olds, we were seeing between 75 and 79% efficacy after a year, relatively consistent across the sites. After 3 years, we've just got this data in the last month or two, again in the 5 to 17-month-olds, remembering that it's 5 to 7-month-olds you'll actually vaccinate, still around 70% after 3 years. You need 4 doses, a primary series of 3 doses, a booster at a year. We tried adding a 5th dose to that. It made no difference, as you can see on the data highlighted. So is this deployable? Well, luckily, Serum Institute know a lot about deploying vaccines in Africa. They're using a single vial presentation, not 2 vials. You have to mix RTSS and its adjuvant. Thermostability, 40 degrees for 2 weeks, is pretty remarkable for any vaccine, very useful for the last mile problem. And the scale of supply, it says here 200 plus million. They can manufacture as much as is needed, and that may well be relevant to elimination when you might need much more than that. So today, in 2024, towards the end of the year, these are the countries identified by WHO to distribute vaccines to. There's a tiny bit of overlap, but mainly WHO decide which country which gets which vaccine, which I don't understand and we're not pleased by. So next steps for malaria development. New indications. Adult use, particularly for women in pregnancy, a couple of trials planned, coming up soon. Elimination trials, I'll come to in a moment. RH5, blood stage vaccine, being combined with R21 at the moment in a trial in Burkina Faso. Look out for results Q1 next year. I think they'll be in the 90% range. And an elimination vaccine is what I was asked to talk about. So here goes. There are 3 antigens that have been around for years, PFS 25, 4845, and 230, being assessed in trials in Africa. That's important because for elimination, targeting the mosquito stage may be the most important, but if you had really, really good anti-disease vaccines against sporozoites and blood stage, it would make it easier for the mosquito stage vaccines to work better. So are we getting any efficacy against infection with an anti-sporozoite vaccine? Here is what we have for R21, measuring not disease but parasite prevalence rates after vaccination. And the good news is that after 6 months, we're getting 65% reduction in parasite rates. So if you're really optimistic, you could say you're nearly 2/3 of the way there. It does go down, like our anti-disease efficacy, but fairly slowly. By the end of 2 years, it's about 50%. So what I think you need to do is put together all 3 stages, and because of the cost of goods of these vaccines, which are dollars but could be cents, I imagine, if you really go up in scale, you could put these all into a single vial. R21 in Matrix M, as is licensed at the moment. RH5.1 showing good efficacy in field trials in Burkina Faso, in-licensed by the Serum Institute of India. That's why the 2 vaccines are being tested together. They could be mixed. And very importantly, Serum Institute, they haven't quite said no to us ever yet, but we are testing them. They're doing Vivax, I'll come to that. They're also doing 3 antigens for transmission. 230D1M from the NIH, Patrick Duffy's group, in the lead, but a couple of other promising ones, particularly 4845 from Shumi Bijwas, my colleague in Oxford. So Umberto D'Alessandro, director of the MRC's unit in the Gambia, with Halidou Tinto, again from Burkina Faso, really got going very quickly on an elimination-style trial with R21. They're doing the trial in 2 countries. They're vaccinating in a cluster randomized trial, all individuals in various villages. They claim this is the first trial ever to look for an effect of mass vaccination, which I think it is. And it started only in May, but already they have efficacy data with whole population coverage of over 70%, showing good efficacy. And as they say here, a very statistically significant reduction between intervention and control villages in clinical malaria cases, but that's not the primary endpoint. The primary endpoint is parasite rates, and those data have yet to come, probably in the coming months. So they're now planning to add in 2026 mass drug administration to the vaccination regime. And remember that, because I don't think any of us in the room think a single intervention is going to eradicate malaria, but drugs, very useful, 60% efficacy over a year. Add that to nearly 80% in children, 70% in adults for R21, and you've heard about bed nets. Together, we should be close. So what we're thinking of doing in addition to that trial in the Gambia is to, sorry, how do I go backwards? Yeah. Is to actually make the 3-stage immunogen. They're all made, just need to be put together. That will need some optimization. I'm pretty confident you can mix them, otherwise it will be difficult. So that's step 1. Step 2, show increasing impact with added vaccine components. Prove you need the 3 stages, not just 1. Drugs, new insecticides, and other tools. And thirdly, most importantly, identify settings to evaluate impact and deploy. So this is where I'll finish. I think that's the strategy. It's not a 2-year strategy, it's a 5 to 10-year strategy. But Malaria No More and many other people from Jeff Sachs on have calculated the economic benefit of eliminating malaria. And it's huge. We're spending $5 billion a year controlling malaria. If you could do it in 3 years, that would be $15 billion you're spending. But look at the money you get back. By 2030, Malaria No More estimate that economic growth in Africa would be accelerated, the GDP, by 127 billion if you could eliminate malaria. Of course, it's money up front is the problem, as we all know. But the business case is extraordinarily strong. And nobody's going to make that if the malaria people in the room don't do it. So that's the biggest challenge, I think, just convincing people that the arithmetic and the numbers are sensible, and of course that the whole thing is doable and progress is being made. So I'll stop with thanks to our amazing principal investigators in the phase 3 trial, lots of other trials going on in Uganda and Bangkok and elsewhere, and hopefully Indonesia soon. These are the leads at Oxford on including Katie Ure, who's now moved on, and Lisa Stockdale has replaced her. Our colleagues at the Serum Institute of India, who have been quite extraordinary and impressive, and I'll be happy to take questions after the next talk.
Thank you, Adrian. And last but not least, for the last of our areas, drugs for the 21st century from the MNV.
Thank you. Good afternoon, everyone. I must confess this is the second time in a month that I come after Adrian, and this is a very daunting task. So, what are we still facing in terms of drug development and the drug space? What are the challenges that we're facing? I think Adrian talked about a few of those things. And so if we start from the right and we go to the left, transmission blocking, Adrian nicely studied, this is a huge issue if we want to eliminate the disease. We need to make sure that we decrease the parasite load that we have in individual, particularly asymptomatic individual. Prevention of relapse, I'm not going to talk about Vivax today. GSK and MMV enter into a partnership. We talked a lot about partnership, and MMV is all about partnership. So we developed the first single-dose tafenoquine for Vivax anti-relapse. The problem that we have with this intervention is that we still need to test for G6PD liability, so it cannot be given to G6PD deficient patient. Pregnant and lactating women. There was a question this morning in terms of TB, what are you doing in the CHIM study? Are you enrolling pregnant women? Well, we just started actually the very first trial in first trimester pregnancy with FICO, I think is here in the room. So Liverpool School and Medicine for Malaria Venture enter into this consortium. Is in Africa, Europe, very first phase 3 clinical trial assessing the anti-malarial medicine in women in the first trimester. And so pregnant women particularly have always been considered this vulnerable population, and being vulnerable had to be protected for safety reason, for good reason. So they've been excluded from clinical trials. So we have no data in pregnant women or women of childbearing potential, because we try to stay, women of childbearing potential, we can include them, but particularly pregnancy, we have no data. So there is a gap that we need to fill. Malaria prevention, we have limited choices. Now we're very lucky, compared to 10 years ago, we have 2 vaccines, not 1, but still, I think that, there are gaps that needs to be filled. And last but not least is resistance. We're seeing artemisinin resistance. We all know the story that happened in the Great Mekong region. And in 2020, when I joined MMV in 2012, we were saying if resistance will reach Africa, that will be a problem. And actually, after a couple of years, they said when it will reach Africa. And in 2020, we had the first detection of a mutation of CALCH13 reported from Rwanda. And we can see in the next slide, so you have a map. Sarah showed a similar map for insecticides. You see a map of the prevalence of CALCH13 mutation in Africa. And it started in hotspot, mainly Rwanda, Uganda, Ethiopia, Eritrea were reporting. But now in the last MPAG meeting, they start reporting also resistance to artemisinin in the southern region in Africa, which is very concerning. If we lose artemisinin, we're putting a lot of pressure on lumefantrine, the partner drug. AL is the main standard of care used as an ACT in Africa and all over the world. And so if you use artemisinin, you risk to lose lumefantrine. And one of the problems is also that the treatments are very complex to take. So you have to take 2 doses for 3 days. So there are 6 doses. And you can see in the graph that you have on the right that the first dose is not a problem. They take the first dose, but then they tend to not take the second or the third. I think that we have all gone through, antibiotics. When you start not having symptoms anymore and the fever goes away, you stop taking antibiotics. It's similar in malaria. And so, in addition, the poor compliance with the 3-day dosing regimen actually contributes to the risk of resistance. So what are the big bets that we have, particularly in the drug space? Leaving Vivax aside, which is not because it's not important, we need to think about Vivax 2 elimination, but I had 10 minutes, so there's so much I can say in 10 minutes. What are we doing with the tools that we have currently on the market, and where are we trying to go with the next generation drugs? So if you look at the global malaria drug portfolio here, what we have done is that we have separated in different buckets. So how can we tackle the artemisinin resistance with the drug that we have today? So first, multiple first-line treatment. Basically, they're taking all the ACTs that there is on the market, and they do rotation to decrease the pressure on the parasite. Triple ACTs, so adding a third component to an ACT, that could help in protecting the dual combination that you have there. And then with Novartis, we are developing ganaplacide lumefantrine. That would be the first non-ACT combination. It's in phase 3. The team presented at LSTM, very encouraging data from the phase 2b study in children. So I think that we have nailed the dose. And now they started in this year, in January this year, the phase 3 study. They plan to finish recruitment next year, planning for success with very good data, encouraging data from phase 2b. We should be launching it in 2026, 2027. Don't quote me on the date. And then we're thinking about lumefantrine resistance, because lumefantrine has been, a stable molecule, but now with a lot of pressure, with artemisinin resistant increase in lumefantrine, we start seeing delayed parasite susceptibility to lumefantrine. We can't talk about lumefantrine resistance, but I think we need to watch that space, particularly given the experience that we have with artemisinin. And so at MMV, what we're doing together with partners is thinking about what are other combinations that are non-artemisinin based that could be the response to lumefantrine resistance. So the first one, easier, so to speak, would be add a third component to ganaplacide lumefantrine. So this is done in collaboration with Novartis, and that could be a single dose. And then with carbamazepine pyronidine, carbamazepine is a novel mechanism of action in combination with pyronidine, developed by Merck together with us. Zydus 19489, it's unknown mechanism of action, refractory to resistance in combination with ferroquine, again, potential for single dose. And the single dose, we've been criticized heavily that we have actually put our bar really, really high in going for the single dose, and 3-day dosing or 2-day dosing is good. But actually we are seeing that, particularly if you're thinking more and more about elimination, about resistance, adherence is key. So having a single dose, it would be absolutely fantastic. Think about those countries that have flooding or natural disaster when the health system is crippling down. Having a single dose that you distribute would be much easier. Then we have what we call the single dose cure combination. And those are all new molecules that they have completed challenge studies, so they have only phase 1 data. But this one could be new molecule that you add on existing combination, or they are the base for a novel dual combination. We've done a lot of progress. This has been a headache for all the drug discovery that work in malaria, because we have pushed the bar higher and higher. And here you see on the x-axis you have the years, and on the y-axis you have the dose. In order to go towards that single dose, we have to decrease the dose that you give. But also in circle, you have the propensity to show resistance. And so if you look at it, moving to the right, so going around 2017, 2018, we start dropping off those molecules that actually had high propensity to develop resistance. And we are having more and more mechanism of action that seems to be refractory to resistant, which gives us hope in reaching that single dose that actually does tackle resistance. So we don't want molecule that have high propensity to resistance even combined together, because that could be an issue. If we move on into prevention, which is, to me, it has been a very neglected space in malaria, and for several reasons. Here you see in this graph the uptake of seasonal malaria chemoprevention. So there was a consortium formed in 2012, the SMC Alliance, and they were distributing SPAC, sulfadoxine pyrimethamine, which is the treatment for, is the treatment for preventing disease in children under 5. And they reported that in 2023, 53 million children were covered by SPAC, which is a great success. 75% protective efficacy reported by WHO in children under 5, 88% in a controlled clinical trial. And again, why is it higher in a controlled clinical trial? Because you make sure that they do take all the dose regimen, whereas when you go into real life, they tend not to. It's very cheap, and as Adrian said, affordability is key. And there was a study, only one, hopefully there's going to be more in the future, that when actually you combine SMC with RTSS, you can see that there is additivity of the two tools together. Challenges remains in prevention as well, and to us the biggest is the limited target population. We're still thinking a lot about those children under 5, and you can say to me, yeah, but this is the high burden where we have the majority of malaria. True, but what about school-age children? What about pregnant women? What about women of childbearing potential? Migrant workers, migrant population. So I think that the situation is evolving, and with SMC we are thinking about expanding that age and expanding that geography, so work is already ongoing, but we need new tools to fill in these gaps. And so the prevention space could look much busier and crowded in the future. Adrian is doing, with the group at Oxford, is doing a lot of work on vaccine, and I think it's beautiful to see it. Monoclonal, we start talking about monoclonal malaria, something that, global health never had before. And so, the jury is still out for that. And at MMV, we are working on a long-acting injectable platform, trying to take on the example of HIV. We've heard about lenacapavir and the fantastic results that they have. And so back 6 or 7 years ago, we thought about how about a Malaron IM, affordable, that actually we can deploy in Africa. Unfortunately, proguanil is not amenable for being formulated for long-acting, but we found a partner drug for atovaquone. And so today we're looking at an intervention that could be really at the cusp between prevention and elimination, because you could have a long protection with a decreased transmission. So we want not only prevention, but we want to clear existing parasites, broader population, and from an access upside, you would have an affordable compound with no cold chain required. So we just started the first in human of the IM atovaquone here in the UK. So we are in cohort 2, going strong. The results look promising. Unfortunately, they're still blinded. I'm not going to show you any data. I'm not going to jinx it. But the idea is to have at the end a cost-effective single injection with a 3-6 months protection. It's going to be a combination of 2 compounds. And you have up there the 2 preclinical data that we got from animal. And you can see how 371 is the derivative of atovaquone. It stays on for 3 months and longer, which made a preclinical absolutely a nightmare because we had to follow up those animals forever. And then you have the new chemical entities, 055, on the right. Same thing. It shows promises that it could actually stay in the blood for 3 months or longer. And the idea would be to co-formulate this as a fixed-dose combination. We have preliminary results that it looks like possible. They're compatible physically and chemically. And so to have a powder for resuspension. So to conclude, I think we started the morning talking about partnership. I think that it's a testament that partnership are needed, not only between an organization and the pharma partner or the academic, but also amongst different researchers that work on different platforms. So we do need treatment, we do need prevention, we do need vector control, we do need diagnostic in order to bring, hopefully, those malaria deaths to 0. Thank you very much.